All right, I think I'll start right now. Just to let you know, I'm gonna be releasing you from DI today. So I'll finish I'll do the clinical review and do the 30 minutes that like the quick DI pearl. So we're not gonna go back to the office. Well, us, because we have like the PNT committee meeting. So after 3:30, this is gonna go an hour and a half. After 3:30, you're just welcome to leave, or unless you want to go back and work in DI, that's up to you. But technically, we'll be up the hill and we'll come back at 5. So technically, you're done after 3:30.
Okay.
All right. That's why I have my stuff with me, so I have to go the hell right away. All right. So welcome to the first clinical review. As you know, this is an hour weekly lecture. It's basically just a review. Basically, I ask you what do you want, and I will do the antiarrhythmic as the first one. I know it's like an annoying topic and it's kind of used in NAPLEX. So, and I had some feedback that to do this topic often. So that's why I'm going to do that topic. If you have any suggestion for next week or the week after, so I suggested that I do oncology. I tried to do oncology before. 1 hour, believe me, is not enough. I had to do it twice. But I mean, I'll do the drugs today, and you can let me know what do you need exactly. Do you need it to be disease state? Do you need it to be drug management of toxicities, or just purely what are the regimens and some kind of pearls on the medications that we use for liquid tumors? This I may be able to squeeze it in an hour, but even chemo man will take me more than an hour. As you will see, I speak a lot. So just to do antiarrhythmics, I know it's an annoying topic. Probably you have all these mnemonics to remember medications. I'm not a big fan of mnemonics. I'd rather to do it like the old way. Well, as you can see, there is no slides. It's going to be all on the board, and this is going to be basic fundamental review of electrophysiology, of cardiac electrophysiology, which is mostly the lecture will be dedicated to. I believe that by understanding the basic fundamentals of electrophysiology, pharmacy level, that would be sufficient enough for you to know your medication. And you will be able to address these EKG changes, the weird that why a 1A will cause a wide QT, why a 1B cause the short QRS. All of these could be addressed if you really understand the physiology and then the pharmacology. And then, so I'm not going to be touch on therapeutics as much as I'm going to review medications. And therapeutics is right there. We can just talk about it anytime. All right. So I'm gonna go ahead and start. So what do you know about cardiac electrophysiology? Try to start from the basics. Well, you know that cardiac is a special tissue. It has its own excitability or automaticity, where an impulse is propagated, maybe all the time, usually on the SA node. This impulse will travel through a conduction system, like a technical wiring, okay, throughout the heart, and every time an action potential passes, a muscle depolarizes and a contraction occurs. Always electrical activity will go before mechanical activity. So if you plot the electrical activity with mechanical activity through time, you will see the mechanical changes will occur, which in terms of pressure changes, relative later to the electrical one. So this is a heart. This is the basic heart, and this is your SA node where the vena cava, the superior vena cava comes to in. So the SA node is the pacemaker, so it will generate an action potential. This action potential will travel through the atrial wall at the same speed, and then it will all propagate to one point, which is the AV node, and the AV node is located in the AV septum, as the name AV. Okay, once in the AV, there will be a 0.1 second delay. Why do you think there is a delay? This is a physiologic, very important delay. Gonna talk about it. Then the electrical activity after this delay will travel down through a bundle of His, so it's like a one bundle, and then it will branch. So we got left bundle branch, right bundle branch, and have you heard about the term LBBB, RBBB, left bundle branch block, right bundle branch block, which is more evil? Left, always left. I can present as a left bundle branch block and doesn't have like an ST elevation. So LBBB is something call it evil. RBBB is not an issue. So there is a left and a right bundle branch, and then fibers system called the Purkinje fibers, the PF, will carry the action potential to the ventricle muscle. Now, 0.1 second delay at the level of the AV. Why is that important? Electrical activity, as I just said, is much faster than mechanical activity. If you don't have this delay at the level of the atria and the atria and the ventricle will contract simultaneously. You don't want that, you want this delay, so you would ensure that the atria will contract before the ventricle. There go ventricular filling to reach your end diastolic volume, which is enough to open up the what's called the aortic valve, and hence to release the cardiac output that you're looking for, because in the end of the day, this is the cardiac function. So AV node, 0.1 second delay, very important. Drugs like beta blockers, CCBs, digoxin when you use it as to rate control. Whenever we say the word rate control, adenosine means that the drug is not working on a channel, the drug is just increasing the refractoriness of an AV node, hence delay, increase this physiologic delay. This is why this is called rate controllers, as rhythm controllers will work on certain channels throughout the conduction system. Primarily the conduction system in the ventricle. Let's talk about basic, boring electrophysiology. Let me ask you a question. You know the cardiac action potential, right?
Yeah, I think so.
All right. Let me give you a test here. This is a graph A, this is a graph B. In A, you have an action potential that is looking like this. In B, you have an action potential that is looking like this. Well, that was like a good idea. All right, which one is the cardiac action potential? I just want to make sure that this is visible. A? Well, what do you think? Which one is the cardiac action potential? It's actually both A and B.
Oh.
Okay. Yeah, I like trick questions. So A and B are both reflective of the cardiac action potential. Now, why is that? This is for one reason only. Is that action potential through the conduction system changes. It's not the same. This is technically the action potential in the SA node and the AV node. This is the nodal action potential, also known as the slow response fiber. It's just a name. It's called slow response fiber. This is the general action potential that is through everything in the conduction system. So atria, ventricle, Purkinje fibers, bundle branch, and this is known as the fast response fiber. Now, you basically thought this is the right action potential. Yes, because this is what we're going to talk about. This is where most of our drugs will work. And this is basically where things comes to become very tricky. So without further ado, I will talk about and dedicate my lecture on this graph here. As for the graph B, which is going to be of very limited pharmacological, as you can see, there are missing some channels here, so therefore it's not going to be of a big deal. All right. So let's go over the action potential here really quick. I'll be using this graph figure a lot, so you may want to draw it or just focus with me. Okay, a normal action potential where anything low is negative and everything up is positive. The membrane resting potential of the cardiac muscle rests about, you know how many volts? Negative, well, negative 50 will be here. Here is about negative 80, let's say, negative 90 millivolts. Now, let me just return to a basic structure. What is the most which is the most extracellular cation? This is intra, this is extra. Sodium, that's why it's 135. Yeah. What is the most intracellular cation?
Oh my God.
Potassium. Yeah, because outside is 3.5 and inside is 135. And where is calcium is living? Calcium is tricky, let's put it extracellular, but technically calcium is intracellular but not in the cytoplasm. Calcium is released from the endoplasmic reticulum based on an action potential. But the net movement is that calcium will, when it opens the calcium channel, calcium will become concentrated in the cytoplasm. But just to know, calcium is not coming from outside, calcium is coming from the endoplasmic reticulum to the cytoplasm. If I open a sodium channel, what's the net movement down to its concentration gradient?
It's gonna go intracellular.
Go intra, so everything sodium will be inward. What's the net movement of potassium if we open its channel?
Outward.
It's going to be outer, so that's your outer movement. What's the net effect of this inner movement? Depolarization or hyperpolarization?
Depolarization.
Depolarization means that you make it more positive. If think of it from there. So if potassium leaves, what's the membrane potential? Hyper, you're losing more positive, so it's going to be more negative in the inside because the positive is getting out. And calcium, we said we're going to treat it as inward movement, so calcium also depolarizes the membrane. So when you see an uprise in the graph, this is a sodium or a potassium opening. There is an inward of sodium inward of sodium or calcium. When you see a down slope, this is probably a potassium channel opening, and potassium is hyperpolarizing. Why is it not the other way around? Because ions moves down to its concentration gradient. So there is no inward movement of potassium or outward movement of sodium, except in the last phase, which is probably that's not going to be of big issues pharmacologically at least. So you start the membrane potential. Now let's start plotting and putting our channels. You start with phase 0. You don't start with 1. You start with 0. So you start with phase 0. I need some colors here. Oh, it's called that colors. Like it is. So you start with phase 0, and phase 0 is basically the opening of sodium-gated channels. So sodium is the main one. This is an inward movement. Yes, it's an inward movement where the membrane potential is becoming more positive. The membrane potential will become at a level of probably around, I think, -40 or something like that, where it's called the threshold potential. And technically, you got this upstroke, famous upstroke of a cardiac action potential. It's like goes in gradual, and then it shoots an action potential all the way to what they call here a phase. Well, here is like a phase, start of the phase 1. This is P0. The action potential is probably going to be +40. This is as powerful as the action potential it can go. Now, phase 1 is is a weird phase. The phase 1 action potential, it's a bit upstroke, furthermore beyond what's in. This is, by the way, this is a voltage-gated channel. Phase 1 is going to be also voltage-gated channel, but a different sodium channels. There are more than 500 types of sodium channels, I think, in the body. So not all sodium channels are the same. Otherwise, any carbamazepine would give you, because it's a different kind of sodium channel. So there is a different sodium channel. We call it the late sodium channel. The late current. You know what drug works on a late current sodium channel? This is ranolazine. This is an anti-anginal drug that is very stupid. It just controls heart rate for patients who cannot tolerate beta blockers. So the late current sodium, this just gives you a small upstroke. Physiologically or clinically, if you're not talking about ranolazine, that's really not important, so I'm not going to waste time on it. Followed by phase 2. The phase 2 is basically what we call a plateau phase. This is what's going on. Here you have a short downslope. So what's happening here? Potassium open, yeah, that's it. Sodium closed, potassium now started to play. This is P2 now. So potassium is going outward, and that outward is bringing the membrane potential a bit. But not going all the way to down, there is some plateau phase here. So what's going on here? Something positive is counterbalancing the potassium movement, and you get this maintained phase or a plateau phase on the graph. So sodium is out, sodium is went back to sleep. Who's awake now?
Calcium.
Calcium. That's why you got calcium opening here now, and you got an inward of calcium, and you got this. So it's not going up because it's balanced between the outward and the inward of calcium and potassium. We reached to that point. This is voltage gated. Calcium got tired. Calcium went back to sleep. So no more calcium here. What is dominating in P3, which is the downslope?
Potassium.
What is it?
Is it potassium?
Yeah, potassium is back in business only, and potassium outward, and it's bringing back full-blown hyperpolarization all the way to even more negative than in resting potential, and then all the way till the end. In the end, let me just tell you about the sodium-potassium ATPase. By the way, all the movements here are energy independent because this is ions are moving down to its concentration gradient. So there is no ATP being used. The ATP, you would use it in an active transport when you are transporting something against the gradient. You know, we had some sodium in, we had some potassium out, we have some calcium in. In the end, what we need to do is what? The heart needs to restore its cation content. Otherwise, you would be having all your sodium inside your heart and after a couple of beats. So, in the end of the cycle, the heart needs to restore. How does it restore? Is the famous sodium-potassium ATPase, which is a co-transporter, an active transporter, hence the name ATPase. It's using ATP to put sodium back in the cytoplasm, back out in the extracellular, and using ATP also to put back potassium to the intracellular, so you get back to the main cation formation that happened before the what's called the action potential. Does that make sense so far?
Yeah.
And then you just carry on to another shoot after another impulse propagates. Just for you to know, while the cardiac tissue is in the process between phase 0 and phase 4, which is the restoration of the PEM potential, it's already in what we call a refractory period, which is known as the effective refractory period or absolute. However, that's not going to be very important. The ERP, the effective refractory period. Once it's in that, what's a refractory period mean?
Refractory.
A refractory period, simply, yes.
Oh, like you can't have a
Yeah.
conduction.
Oh, yeah.
Yeah.
It's the resting time.
It's exactly. It's like somebody's at work and you're coming and you're already busy and somebody comes in and said, "Hey, would you do this for me?" And said, like, "Get away from my head. I have enough to worry about right now." In other words, no matter how much a strong electrical activity that happens, if you get a wire and zap the heart won't comply and start an action potential unless it finishes and it gets off its refractory period. Think of it, your refractory period is like your 30 minutes break or 15 minutes break that you won't do any work. Don't bother me. I'm finishing my refractoriness. I'll get back to business when I finish my time.
Mm-hmm.
That's going to be important to understand how lidocaine works. That's why I'm using that example. So, in other words, after your refractory period, if something happens here, it can shoot. Just worried about this. All right, I think we're moving on a good pace here. Now, just to go over the slow conduction, slow response fiber, just to maintain here. Normal, this rest at negative 80, this rest at negative 40 or 50. So it's already more positive than that's why it can shoot, that's why it's more automatic, that's why it's closer to being positive, that's why it sets up the rhythm for the heart. Okay, once you have, in phase 0, you don't have a phase 0, you start from a phase 1. Simply because there are no sodium channels in the SA node or the AV node. In other words, your antiarrhythmics that works on the sodium channels would have no effect on SA node or AV node. The phase 1 is technically, so if sodium is out of the equation, what's making the upstroke here? Calcium. And as you can see, it's not an upstroke shoot as that one, it's slow. That's why it's called slow response fiber. So calcium is there, and then you don't have a plateau phase. You have like a mini plateau, which is basically calcium is going to sleep, and who's awaking now? Potassium, yeah, that's it. So potassium here, this is phase 2, potassium opens, brings back the membrane potential all the way to 0, and then just like a restoration, and that's it. This is what? It's a 3-phase system when there's no sodium channels.
For the calcium, that movement is inward or outward?
It's inward. It's always physiologically.
Okay.
Calcium cannot leave the cell. calcium has to, not, again, it's not technically, and they put it as inward in the references, but if you want to think about it, calcium doesn't come outside. Calcium, the serum, the free calcium or the ionized is very minimal. Calcium is basically liberated from the endoplasmic reticulum to the cytoplasm. The net looks like an inward. The net effect is calcium making a membrane more positive, but it's not. It's like released from a different room without coming from outside.
Yeah.
But it's denoted with the letter IN, so it's an inward when you want to plot it. Okay. As you can see, we don't have sodium channels. We don't have, so any antiarrhythmic we'll be talking about, the bulkiest thing is going to be here. By the way, when we talk about classes, there are no many classification system. And technically, we have this von Williams classification system, which is pretty much, it's the best of very bad situation, because technically, putting an antiarrhythmic and define it to a single class, or attribute it to single type of channel, is a bit, is not very wise, since that antiarrhythmics often have multiple channel effects. And these multiple channel effects will be reflected on their side effects and their EKG changes. Before getting into that, we have 4 classes of antiarrhythmics, correct? I won't be talking about class 2, and I won't be talking about class 4, because one thing, they are beta blockers and CCBs, and I already talked about them in the AV node. And these drugs just increase the refractoriness of the AV node, delay conduction, and it's, oh, by the way, I want to do EKG also, quick EKG. Just for you as a review here, P wave, QRS, a T wave. What's a P wave mean? What's happening in the heart?
Is it repolarizing?
It's depolarization. It's an absolute.
Depolarizing?
So P wave is atrial depolarization. What's a QRS? It's ventricular depolarization. And what's a T wave?
That's a repolarization.
That's a ventricular repolarization. Where is atrial repolarization? It's so small you cannot see it. It's actually behind the QRS. Because when the ventricle contracts, the atria relax, and technically the ventricular atrial repolarization wave is obscured by the QRS, which is the ventricular depolarization. What's important here is not the PQRST. What's important here, I want to tell you to know this, the PR interval. Any drug would affect the AV node would cause the PR interval to become longer or shorter. Any drug that would affect the AV conductance, that would delay AV conductance, a beta blocker, a CCB, and digoxin at high doses, what's going to happen to the PR interval? It widens. That's why the EKG change with beta blockers, CCBs, and digoxin is AV block, which is PR widening. So technically, that's it for beta blockers in terms of what we want to talk about. The rest about beta blockers and CCBs, that's basic side effects. I'm not going to talk about this. This is like straightforward. But just want you to know that beta blockers, CCBs, high dose digoxin, their toxicity, their overuse is, by the way, AV block, and their EKG change is PR interval widening. So I'll keep the EKG because I'm gonna go back to my antiarrhythmic. So we have 4 classes. Poor design, but however, this is the best you can do right now. So we got class 1. I'll be talking about class 1 and class 3 today. I already covered now 2 and 4. So class 1 are the infamous sodium channel inhibitors, and class 3 are the infamous potassium channels inhibitors. Now, there are 3 types of sodium channels inhibitors to make it, well, we have to make it confusing, right? So there is 1A, 1B, and surprise, surprise, 1C. Why do we have 3 types of sodium channels? Because we have 3 different conformations for sodium channels. This, what determines a 1A, 1B, and 1C is largely defined by 2 things. First of all, in what conformation the drug is blocking the sodium channel, and how fast or slow it is binding and releasing effect. You know, these drugs, binds and depends on how slow they release, or how slow or how fast they release, or intermediate, we have the 1A. Therefore, the 1A is always known as the intermediate. This is the release rate. The 1B is known as fast release, and 1C are slow release. Keep that in mind. It's also not about the degree of affinity or the pharmacologic, is also different in what conformation the channel is being blocked. And basically, this is the full depth of the information of this clinical review to understand and how to be able to relate this to the EKG and the action potential curve. Once you understand this, I think class 3 you would be able to say already without even having me to guide you through it. Let me just do some channels here. We won't be using the SA node here anymore. Channels is, again, anything up is extra, anything down is intra. So sodium channels, when it's open, or in the beginning here, before the phase 0, it's resting in the resting potential. When the action potential is not there yet, it is what? Closed or open? It will be closed. Yeah, before anything happens. Okay. Funny thing is that sodium channel has two sets of protein to close it. One of them is called the M protein. Oops. One of them is called the M protein, and the other one is called the H protein. It's like an H. In the first conformation, this is called the closed resting state. So the channel is closed and it's a resting state. Just don't worry about the name now. You're gonna understand it later. When the action potential comes in and the channels will start the phase 0, sodium start to going up, so the channel will become what? Open. And when it's open, which protein got displaced? M, because H is already displaced at this phase. So M become open and H still open. Oh, don't know how to do an H anymore. Oh, it's like an inverted H. So N is open, therefore sodium is coming in freely now. No sodium here. This is what we call an open state. Now, it's gonna be closed, but the idea is that when it closes, the sodium channel won't go back to the resting state. It will enter a closure but refractory state, which we call this, which is going to be open M but closed H. H will close it. Once the H closes, and there is no movement anymore. Once the H closed the channel, this is called a closed and refractory kind of closed. Why? This is very important for the sodium channel to relax. This is where things get really tricky. This is why lidocaine is a great drug, because it works on this state right here. I'm gonna get back. Now, once it's finished its refractory, so like I took, again, the word refractory here, think of it as your break, as your lunch break. Nothing can bother you, I hope, during that time. So here, the sodium channel won't even comply to any kind of potential, and then eventually it will go back to this state where H opens, M closes, and everything goes back to normal as the cycle is going. Is this clear so far?
Can I ask one question?
Yes.
For going from open to closed again, so that's phase 1 or 2?
This is phase 0, pre-0, 1, and that's it.
Oh.
2 started to be,
That's
yeah, we started calcium here, not really bad, that's it. Sodium story ends with the end of phase 1. Okay, depends on which conformation this antiarrhythmic would work, will have it denote. So, class 1A. Class 1A are good, bad, do you know the medications?
Class 1A, I did at one point.
Class 1A, they put mnemonics for it. And no, the famous pharmacy mnemonics that P4 uses it is the food mnemonic, which is what's better than food? Nothing. That's the only way. That's the only thing you're thinking about probably right now. So it's the what they call quarter pounder cheeseburger.
Pound with lettuce and mayo.
Anything, lettuce, mayo, shawarma, sushi, I don't care. The idea is that I need to understand this and don't use mnemonics. By the way, the medical students have much better mnemonics than ours. We use quarter pounder cheeseburger, they use the Queen proclaims Disos pyramid. So it's quinidine, procainamide, disopyramide. So the Queen proclaims Diso, a guy named Disos pyramid. Quinidine.
And it makes you remember it better.
Yeah, see, like if you think about food, it's quinidine, procainamide, and put it as PA, and DA, which is disopyramide. Okay, despite that these are 1A. 1A means, by the way, I don't care for which conformation. 1A means it blocks the channel here, by the way. But this is not important for 1A. The only channel I want you to think about the conformation is to relate this to the 1B drug, which is, I'm gonna get to it shortly. Quinidine, procainamide, close the channel in the closing resting state. Not that big a deal. What you need to know about this is these are not really quite the sodium channels. They are tricky ones. These are sodium channels. 1A are not just sodium. These are sodium, potassium, and muscarinic receptor 2 inhibitors. Their effect is by far the worst kind of effect. You can see the madness that's going on here. First of all, it's intermediate. What we like, our antiarrhythmic, we want it to be short or fast? Fast or slow?
Fast.
Fast, we want it to come in, hit it and leave. That's it, go home. We don't want something to come in and like sit there and be all the time. It may be handy if you don't have a structural disease. When you have a structural disease, slow release is a very bad thing, and I will get to it also very shortly. And you will be able to relate why 1C is never to be used with a structural heart disease because of their slow release potential. 1A have an intermediate release, so that's not a big issue. 1A inhibit the sodium in the close resting state, also not a big issue. What's the issue is these nasty drugs are potassium and muscarinic inhibitor. Remind me, what's a muscarinic blockade will cause? Think of atropine effect. So what's the net effect on the heart rate atropine does? Tachycardia. We use atropine to treat bradycardia. Symptomatic bradycardia, 3 shots of atropine, 5 minutes apart. That's how it you do. And then if it didn't work, you do percutaneous pacing. So atropine is like the anti-beta block. So first of all, these drugs would increase the heart rate, something really bad for a patient with ventricular arrhythmias or atrial arrhythmias. Actually, you did how many rotations of cardiology right now?
I did like 2,
Yeah, how many times you seen this drug?
I haven't seen
Haven't seen them, yeah. Where are they?
Because they pro-arrhythmic, really.
Very pro-arrhythmic. You don't see them. It's actually archaeology or right there in the garbage. These are very bad drugs because, first of all, they are tachycardic meds. Okay, let me now show you the figure what happens here, and please think of what's happening. If I block sodium and I block potassium, and let me use a different color so something more shining here. Okay, I'll put, if this is the normal, and I will draw it with a 1A antiarrhythmic. What's happening is you're blocking sodium. So if you're blocking sodium, what's happening to that slope here? Is it the same, shifting to the right or shifting to the left?
Shift to the right.
Shift to the right, yes. So it's coming like this. This is the first thing that's happening. This is the sodium inhibition compartment. Now, okay, if this is a pure sodium channel inhibitors, everything else should be the same, and you should stop here and go here, and this is all what you can have. But no, this is not the total issue. So you got the calcium effect and you got the potassium. Now, when the potassium is the main channel, which is phase 3, what do you think is happening to the graph? By the way, this should not be like this. This should be here. So what's happening now? At the slope of phase 3, potassium is being blocked. So is it shifting to the left or to the right? To the, it's actually shifting to the, no, it's actually the same thing. It's becoming like this now. It's delayed, instead of potassium coming out, it's not coming out, so it's remaining, and the negativity, the movement is becoming slower. Okay? So, look what happened here. This is where the original refractory period stopped. Can you relate to that now? What's happening is the action potential curve got widened. With widening of the action potential curve, refractory remained the same. So what's happening, instead of finishing your cycle with your refractory period, the refractory period is over and you are still not there yet, not finished yet. So what's happening is, here at this time, your lunch break went from 30 minutes to become 20 minutes. So technically, while eating lunch, I can come and give you work, and you cannot say anything about it. I'll never do that, of course. But what's happening here is that if an action potential happens, if the heart is stressed, if the patient is stressed, or got struck by lightning, no, not really. But if you have an ischemia, basically, the heart will work overtime, because when you have ischemia, the principle what's going on in ischemia is that there is dead tissue. And when there is dead tissue, the living tissue is working in overtime to compensate for that tissues, because in the end, the main function of the heart is to deliver that amount of blood per beat. So it will do whatever it can. So when you give this, an antiarrhythmic that is shifting the action potential without affecting the refractory, if a strong impulse can originate here, and instead of going back to sleep, it can shoot another one, and that's arrhythmia. And this is VFib. That's why what we call 1A is a strongly pro-arrhythmic. That's why blocking potassium channels is always giving you this widening of, so you know for sure a class 3, a potassium channel inhibitor would not affect the sodium phase and would just like widen the potassium phase, and the net effect is the same. Now, what happens on the EKG? When you widen your action potential duration, what's happening? See, it was like this, now it's become like that. This is more depolarization, correct? You're depolarizing more. Where is the depolarization phase here? QRS. What's the effect? Widening of QRS. This is the first thing of 1A. So 1A, increase QRS. This is not the full story. Any drug that inhibits potassium channel will delay the repolarization phase, correct? Isn't it delayed compared here? Delaying repolarization phase, what's the net effect on the EKG? Where is ventricular repolarization?
It's the cure. T-wave?
T-wave is the actual mechanical repolarization. Where is the electrical repolarization? Yeah, QT.
Oh,
That's QT interval widening.
Oh.
This is how QT prolongation occurs, by the way.
Oh.
No potassium, nothing is potassium. You are not, by the way, this is going to be widened, but again, this is the mechanical manifestation of the QT. It's somewhere in here, so it's the QT segment that's going to be widened. Class 1A, widen QRS through the sodium component and widen QT through the potassium component. Without anything, if I want you to say what is class 3 is doing, is going to be just QT prolongation from the potassium component. That's why these drugs are terrible drugs. Now let's talk about side effects, individual. So all of these, the pro-arrhythmic effect is going to be there. These drugs, we use them rarely for ventricular arrhythmias. We don't use them for atrial arrhythmias. Depends on when the site of arrhythmia. So chronic VFib, chronic VTAC, technically you use amiodarone now, but this, in certain situations where amiodarone is contraindicated, you may use quinidine or procainamide. However, these drugs are limited by awful side effects, which is unrelated to the what's like the full cardiac stuff. So quinidine, what are the side effects? Quinidine side effects is like aspirin or salicylate toxicity. It is extracted from a famous tree called cinchona, just like aspirin is extracted from a tree called willow bark. Cinchona tree is an alkaloid, which is a quinidine is an alkaloid. Anything that has an ene is an alkaloid, by the way. Atropine, heroin, quinidine. It's an alkaloid, means an alkaline. And Syncona causes a set of side effects, which are, as I said, it's like aspirin salicylate toxicity. So it's going to be tinnitus, it's going to be metallic taste, GI side effects, and drug fever. This is salicylate toxicity with the acidosis, of course, or the mixed acidosis alkalosis. But Syncona, I'm relating it to aspirin so you'd remember salicylate toxicity. Drug fever, GI side effects, very bad GI side effects, and tinnitus. This is quinidine. Procainamide side effects is interesting. What's you know about procainamide? Two things I need you to know. This is a drug that is associated with is like a set of medication known to have what we call DIL, or drug-induced lupus. Alongside hydralazine, tetracycline, amoxicillin, isoniazid. Procainamide is a famous example for drug-induced lupus. Actually, when a patient has lupus, the first thing comes in, the rheumatologist comes in, never give procainamide, never hydralazine, never augmentin, never tetracycline, never isoniazid. So procainamide, it has a drug-induced lupus. This is number one. Number two, procainamide has an active metabolite called N-acetylprocainamide, or NAPA. NAPA is a potassium channel inhibitor. Procainamide is a sodium channel inhibitor. Patients who are slow acetylators, or fast acetylators, let me say, because N-acetylprocainamide, so the metabolite is acetylated form of procainamide. Patients who are fast acetylators have more NAPA, have more arrhythmias and hypotension. Therefore, NAPA on fast acetylators is very bad. Procainamide on slow acetylators is also bad. Either way, you're getting accumulation. If it's slow or a fast, wild types do well. So two things about procainamide: lupus, and I'm not going to talk about lupus symptoms, and acetylation issues, because NAPA is a potassium channel inhibitor. So this effect will be augmented in fast acetylators. Disopyramide is just a bad anticholinergic drug. And there is nothing worse, and hence, by the way, here we go. This is the antimuscarinic here that we talked about. Anticholinergic side effects are something very annoying to live with. Imagine living in a state of constipation, urinary retention, dehydration, dryness, eye dryness, ocular dryness, xerostomia or dry mouth, and blurred vision. Not to mention the arrhythmia from M2 inhibition. So disopyramide is a full-blown anticholinergic, terrible drug to live with. No patient can tolerate it. Now, 1A. How much do you hate 1A right now? A lot. I cannot do that. I have to make you love drugs. So how about 1B here? Let me tell you about these great drugs, these life-saving medication, which are lidocaine and phenytoin, PHY, and the oral lidocaine, which is it's called Maxilitine. Not an oral lidocaine, but it's called Maxilitine. There's a drug called tosiramide. I don't know if it's here. Because these two are injectables, phenytoin, lidocaine. This is not fosphenytoin. Fosphenytoin, when we use it for epilepsy, we need fosphenytoin. Fosphenytoin gives us idea to push more phenytoin and delay the cardiac effect. When you need the hydantoin for an arrhythmia, you use the phenytoin. The limitation of IV phenytoin, the difference in the side effects of IV phenytoin compared to oral phenytoin is that IV phenytoin has hypotension and bradycardia. This is not good for if you're treating seizure, but when you are treating AFib, or not AFib, sorry, a VTAC or a VFib, you need that, you would push phenytoin, not fosphenytoin. And Maxilitine is just the oral form. These drugs are amazing. First of all, we already said that fast is excellent. When it's fast, it comes in very fast. Finish the job, go home, that's it, out. This is good. That means it's a great drug for acute conditions. I'll never use it for chronic conditions. But what's important is 1B blocks the channel here. This is where lidocaine works. Now, why is this important? You know, as often these drugs are usually, they say, these are the drug of choice to treat ventricular arrhythmia or VFib or a VTAC, but this is not the complete sentence. The sentence is missing one thing: in patients with ischemia. These are, and technically most cardiac patients unfortunately have ischemia or have ischemic disease. Now, what's happening in ischemia? In patients with ischemia, the sodium channel, there are some lost sodium channels. What's happening is that, think of it here in DI. Normally we have 3 students or 3 researchers. We have a sufficient number of consults. We distribute the work by knowing that we have 3 researchers, so we're very comfortable. This is our normal physiologic. Okay. Say that unfortunately one of the students was not able to come to the service at that day or for more than days, which is unfortunately, let's say, like ischemia, where the tissue is not able to work, or thirdly, of course not for the student, but the tissue is ischemic, hypoxic, anoxic, necrotic, in other words, dead. Okay. What's happening here is that if we don't have enough students and we have surge of consults, urgents coming in, what's we're gonna do? Well, we're not gonna do this again, but what a nasty preceptor would do would kind of comes to the student and tell you what, hey, by the way, today you have no lunch break, you're working extra. You need to, again, because why? Because we have a function, we have a need, which is what? To get this number of consults. This is the same thing with the heart. The heart needs to get this amount of volume. Doesn't matter what's alive or what's dead, needs to be done. The important thing, the brain needs its blood. So what's happening in ischemic patients, this is pre-lidocaine, the sodium channel will lose its closed refractory state, will sacrifice its lunch break, and start going back to that state. In other words, the sodium channel is sacrificing its release, its rest time, and it's not getting its full time in the conformation that is where it goes to sleep. Does that make sense? Yeah. What lidocaine does, lidocaine increase the blockade in this state. Lidocaine will come very quick, and it's like coming to these students and say, shh, relax. You don't need to work overtime. You don't need to sacrifice your lunch break. In other words, take the refractory period, you're done, just relax, and then you can go back to work. Mm-hmm. That's what lidocaine is doing, phenytoin is doing. This is why closing 1B in ischemic patients, and when is this going to be apparent? In ischemic patients, when the heart is dying and other tissue, the healthy living tissue, the remaining tissue is working extra time, sacrificing its refractoriness, so lidocaine will come in and say, shh, relax, don't sacrifice your refractoriness. The volume will be met, the cardiac output will be met, just take your time and go to sleep and work when you are able to. This is what lidocaine does. That's why these drugs decrease mortality in patients with VFib who have ischemia. This is what an ACLS protocol we do in the second resuscitation when it's a VFib or a VTAC. If it did not respond to the first shockable rhythm, you do either lidocaine or amiodarone. Tell you a secret, yeah. But secret for your info, drugs don't work for ACLS protocols. Drugs are being used like lidocaine and amiodarone just because there's nothing else. Technically, to be honest with you, the only thing that works is shocking if the rhythm was shockable and resuscitation. But drugs don't work for patients with VFib, VTAC, but you use it as customary, as something you need to do, part of the protocol, but the evidence for them, they don't work. But you still use them, because what's that? You're not gonna like save a lidocaine at 20 cents over a patient's, I can, and maybe in 1% of need, So these drugs, that's it, I'm done with them. I think we're back to loving antiarrhythmic. These drugs are amazing. Let me put them on the graph here. On the graph, what's happening? These are sodium channel inhibitors, and these drugs makes the action potential in the contrary. They decrease the duration. They make the cell goes to become in more refractory period. So in other words, these drugs also delay sodium because it's a sodium channel inhibitors. but the drug really is ending the action potential way earlier. It's not like when it's normal, it's not widened, it's actually, this is what a 1B, it's very short. This is 1B, this is normal, this is 1A, and I only have 1C remaining. So what's happening, and this is your refractory period here. As you can see, the 1A crosses, so the action potential duration is widened, while normal is normal, and 1B decrease the action potential duration. Decreased, the doesn't matter if you have an impulse. The propagation, the cell will go to sleep, even they are still, it's like you had your 8 hours of sleep and you still have, and you are good, you are still sleeping. It's like sleeping over a weekend, where you technically, you have so much time to, well, not for you, you're studying, but, well, I work on weekends, so don't say anything, yes. So, it's that's the issue, I hope you understand it. So, what's the net effect? We say if we widen the action potential duration, we have QRS prolongation. What happens if we shorten it? Yeah? So, the net effect here is short QRS. What's the effect on QT? No effect. We're not talking about potassium here. We don't have potassium effect. Okay. Now side effects. Lidocaine side effects. If you do it IV, we're not talking about the topical. IV lidocaine causes seizure. It's a sodium channel inhibitors. Sodium channel inhibitors are in the heart. That's the arrhythmic effect that we like. Sodium channels inhibitors in the brain. That's seizure. Phenytoin side effects when you do IV. Let's say gingival hyperplasia. That great coarsening of facial features, hirsutism, acne, right? Wrong. This is chronic phenytoin. We're talking about shooting IV phenytoin. So we have neurologic side effects, hypotension, and bradycardia, which is what we are using it here. You won't have the coarsening of facial features, the acne, all these kind of things, only with chronic phenytoin use. IV, you have CNS depression, the diplopia, the ataxia, the famous vertical nystagmus, because all nystagmus are horizontal, phenytoin nystagmus is vertical. Nystagmus is the pupil movement. So nystagmus usually is a horizontal. When it's vertical nystagmus, it's most likely phenytoin toxicity. And maxillatine is just maxillatine, I don't know much about it. It's just like GI side effects. Last thing for the day is 1C, the slow conduction fibers, the slow response, the slow releases. In arrhythmia, a slow release means the drug will bind, and oh, by the way, these are pure sodium channel inhibitors. But so when it's a pure channel inhibitor, no effect on close, they actually block this channel here. This is where a 1C comes in. So whenever the channel is open, it's gonna block it and put it back in refractory. The cell will back, which won't affect the refractory period. In other words, a 1C antiarrhythmic will only be like this. It will delay the NA, just like here, but instead of ending it early or ending it late, it will end it at the same thing. So action potential duration is not really affected as much as it does with like a 1E. So 1C is here, and it's ending like normal, so this is a 1C. So 1C is pretty much, this is not very important. 1C is, the important thing is they are slow releasers. What happens is, when the drug binds in, it releases very slowly from the channel. When it releases very slowly, it means that in antiarrhythmics, just like antiepileptics, we have this called, what we call a use dependence effect. This is like basic pharmacology here. A use dependence effect means that when the tissue is working faster, the use of the drug or the effect of the drug would be more, right? That's why we give like lidocaine in painful tissue, because this is where pain is. Lidocaine is being utilized where the tissue is mostly excitable. A use dependence effect is not doing good for a 1C because a use dependence effect for a 1B is not an issue. The faster the heart rate, the more potent the inhibition. However, it's a fast release, so it will lose, it doesn't matter. And slow conduction and slow response antiarrhythmic, slow release antiarrhythmic, if the action potential is very strong, again, in the case of ischemia, where the heart rate is working faster, the inhibition effect of a 1C is more pronounced or lower pronounced than normal tissue. The faster the tissue is, the more the binding. But it's what? It's slow release. So the effect will be, in 1B, both of them, 1B and 1C, will bind the same at the fast rate. The release is going to make the trick for the drug. 1B releases very fast. Fine, so it comes in, this is how I want my antiarrhythmic. I'm using it acutely. I want it to work fast and to be released fast. But the 1C, it will release very slow. So you got this discrepancy here, a drug that is coming in and accumulate the heart, and it's not leaving it at the rate it should be. Therefore, a 1C drug is never to be used in structural heart disease patient in ischemia. It's the exact opposite of lidocaine. The drug will come in and simply won't leave the heart because the ischemic heart is more excitable, and the more excitable, the more inhibitable. And that's not an issue, and more inhibition is good, but with a slow release, the inhibition will be so prolonged, and the antiarrhythmic effect will end up being proarrhythmic effect. So 1C, great drugs for atrial arrhythmias, but never for what? Structural heart disease. These are the famous flecainide and propafenone. These are the drugs that we love for AFib, which is an atrial arrhythmias. These are never for ventricular arrhythmia. 1A and 1B are ventricular arrhythmias, so VFib, VTACs. But this is more of chronic, this is acute, and this is atrial arrhythmias. What's happening is these drugs are known as to be very famously known as the pill in pocket. When you give quinidine, when you give lidocaine, well, that's going to be IV. When you give a class 3, when you give a drug that can affect the QT segment, what do? In practice, if I tell you this drug can increase QT prolongation, so what do you do if you want to give it to the patient? You would
give it EKG.
Yeah, you would monitor with the first dose. None of these medication can be started without EKG monitoring. The only thing you can do is this one, the one that has no effect on the refractory period. It's stable, it's just delayed sodium. So that's why we call them pill in pocket. You could give that to the patient and tell them, go start it at your home. I don't need to monitor your EKG with this because I know there is no QT prolongation with these drugs. The only downfall of these drugs is that if the patient is ischemic, you cannot use it. If the patient have a structural heart disease, anything from angina to full-blown heart failure, that's it. The pro-arrhythmic effect is going to be more than the anti-arrhythmic effect because of the slow release. For a normal cardiac tissue, this will not be an issue because you have healthy tissue, you will be able to. So these are the agent of choice if you are pursuing rhythm control in AFib patients with no structural heart disease. Hypertension, not an issue. Left ventricular hypertrophy, that's it. No, think of something else. Probably immunoderm is going to be there. Is this clear? Mm-hmm. The net effect is a drug that pushing potassium, sodium. The net effect is a bit widening. I didn't really show it very well, but the net effect is increased QRS. What's the effect on QT? No effect. Again, no potassium. So these 1A increase QRS and QT because they have potassium. 1B is decreased QRS because the action potential duration is decreased. 1C is increasing QRS without the QT because it's a potassium channel inhibitor. Is that clear? Technically, I'm done. Class 3, which is the potassium channel inhibitors, if I plot them here, you would probably already know the effect and the EKG effect. What's the EKG effect of these drugs?
Increased QT.
Increased QT, period, that's it. What's the picture here? Well, they won't be affecting the sodium, so the
Oh,
sodium will
I see.
become the same, everything goes the same. But here, when you block potassium, prolonged, when you got this prolonged, you have the same issue as 1A, QT prolongation, proarrhythmia, which is action potential still ongoing, while refractory is done, and a proarrhythmic effect is at risk here.
That's class 3, you said?
That's 3 here. And this is 1. Oh, class 1, class 3, potassium channel inhibitors. These drugs are quite high numbers. These are amiodarone, dofetilide, sotalol, ibutylide, which is a IV dofetilide, and a stupid drug called dronedarone. It's so stupid I'm not going to write it. I'm just going to tell you the story. Sotalol and dofetilide, these are agents to be used for both ventricular and atrial arrhythmias, but these are agents to be used if only if you have MI. If you have heart failure, you cannot use them. When you read AFib guidelines, you would see that if the patient has no structural heart disease, use 1C. If the patient has ischemic heart disease but no heart failure, use dofetilide or beta blocker, which is sotalol. Sotalol is a beta blocker with a potassium channel inhibitor. And if the patients have heart failure, amiodarone is preferred. If you cannot do amiodarone, you may consider dofetilide, Ticosin. Ticosin is a very important drug because, let me just talk about Ticosin, which is dofetilide here. Ticosin has no, by the way, here we are worried about interactions because any interaction, anything that affects the drug level will cause QT prolongation. Dofetilide is a hell of a QT prolonging drug for one reason. This has a very simple kinetics, but it's a strong associator of, I think, OAT, organic acid transporter. This is a kidney transporter that actively, pump the drug into the tubule. It's not filtered. This is probably shared with more than 30 medication. Thiazide diuretics are, loop diuretics are among the drugs, metformin, cimetidine. These drugs are often pumped through the probenecid. These drugs are often pumped using OAT. When you have a patient on thiazide, which is most likely because we're talking about a cardiac patient, the use of thiazides with dofetilide, and I find this very important, is contraindicated. This is an X interaction. And you'd be amazed like how many don't know dofetilide cannot be used with HCTZ. So dofetilide being an OAT, sharing the same carrier with so many medications is a bit downfall, a bad thing for the drug. Quickly on amiodarone, the famous amiodarone, the full-blown iodine known drug. Amiodarone can hit every organ beside you, except your kidney, technically. CNS side effect, yes. Skin, blue discoloration, you look like a Smurf. Okay, and photophobia, you got optic neuritis. What else do you got? Cardiac, you got bradycardia, and you got, bradycardia, which is the antiarrhythmic effect. What else? Liver, increase LFTs. What else? Thyroid, hyper or hypo? Both. And I will touch, I don't have time, I can do it in another program. There's only a topic just for amiodarone thyroid. What else? Lung, what's happening to the lung?
Pulmonary, what was it, ischemia?
Not ischemia.
What is it called?
Fibrosis,
Yeah.
pulmonary fibrosis. What else? Did I miss anything? Did I miss an organ? Well, I'm not going to talk about pancreas or stuff, but this is it. This is the gist. The issue is that the fibrosis, whenever you have fibrosis, you're done deal. You'll never use amiodarone. When you have thyroid issues, you treat the thyroid issue while continuing amiodarone because amiodarone have a very long half-life and it's not discontinuing, it won't be of any, so just treat the thyroid. Skin, it's not pleasant to be blue. You would be prescribed fluoxetine. So, it depends on the skin manifestation. Cardiac is bad, and most importantly, the drug has a lot of side interactions, PGP and CYP3A4, being that makes it susceptible for interaction, which is QT prolongation. Let me talk about dronedarone really quick, and then we're done. Dronedarone was a drug, amiodarone per a 200 milligram tablet, you got pretty much about 10 milligrams of iodinized iodine, about 60, but 10 of them will become iodinized. Not an issue, right? 10 milligrams of iodine. You know what's the requirement daily amount of iodine? It's about 100 microgram. So for one dose of amiodarone, you're taking about month's supply of iodine, what you need. You would make sure, you would really become very sure that with the 1 week after amiodarone dosing, you are already had your thyroid with your annual need of iodine. And that really becomes problematic because there is no other gland in the body can that process iodine, only the thyroid. So you could bet all the iodine from amiodarone is going there, overwhelming, and depends if you have a thyroid, an adenopathy, you would have hyperthyroidism, and if not, you would have hypothyroidism, and that's called Wolff-Chaikoff effect and Jude-Basedow effect. That's a whole different topic, and I can talk about it if you have a question. That's a whole different issue there. So what they did is they said, okay, let's do an amiodarone without iodine, and hence come the dronedarone. Big drug, Multac, was very famous. How many times you see it given?
I don't know.
Yeah.
I don't remember.
Where is it right now? It's in the garbage next to Quiddy. Why the drug is really bad? The drug came as a big blockbuster medication, amiodarone without the thyroid, because amiodarone you're gonna take it and like a short half-life, 1 week compared to 60 days. That's what makes it a good thing. Came in the study called Athena trial, which is the dronedarone showed increase like a good for AFib patient. Oh yeah, approved. Okay, and then once we practice some post-marketing results and some the post-hoc analysis of a study called Andromeda study, and showed that in a subset of population who have heart failure, mortality was higher. The drug increased mortality in heart failure, and when did we use amiodarone?
A lot of times in heart failure.
In heart failure patients. So the drug is basically failed to it doesn't do thyroid, but the idea is that it increased the mortality of heart failure where amiodarone is needed, where the drug is needed, because if you don't have failure, might as well just use sotalol or anything else. So that's why the drug sucked big time and it's not used in practice anymore. All right, nice, we're done. I'm just gonna continue here. So technically the clinical review is over, but I have a DI Pearl. It's the first day of rotation for you, kind of the first day of DI activity rotation. So I'm gonna do my Pearl here today and let you go, and I'll go up the hill for the committee. So do you have any question? Oh, by the way, my DI Pearl is going to be about stats, something I do in every DI Pearl. So it's just like a quick review. We're gonna do a lot of stats in Journal Club, but we'll not be talking about observational studies. Most likely we'll all do interventional studies. Okay. So might as well I review observational studies for you right now.
Oh.
Technically my Pearl is of two sections. Let me just make sure that we are good in time and then I have not. Okay, let me go over this really quick. Level of evidence. Level of evidence is of when we're doing DI, we have to evaluate the evidence. The idea is that when you're reading a study, this is for an individual study. This is not the strength of evidence that we use in our DI consult. The strength of evidence that we use when we write a consult, this is just to validate how strong all the evidence that we are using it to get a recommendation. Level of evidence here is you evaluate a single study. Let's say, for example, a Journal Club here. So level, or a meta-analysis for that matter. Level of evidence is of 5 types. You got level 1, level 2, level 3, surprise, surprise, 4, and finally 5. 1 being the best, 5 means suck. So level 1, what makes an evidence of a higher level? So there are many factors. First of all, is it interventional versus observational? Is it prospective versus retrospective? Is it controlled? Is it randomized? And finally, is it powered, or power analysis was done? I won't be talking much about power because we're already doing bad in time, and we're gonna have power discussions when we do journal club. But power, I'll be just define it very fast for you now when I talk. A level 1 evidence, let's fill it out. When you want the best level, is it interventional or observational?
Interventional.
It's interventional. When you do the best thing, is it prospective or retrospective?
Prospective.
Do you want it to be controlled?
Yes.
No, yeah, definitely. Do you want it to be randomized?
Yeah.
Yes. Do you want it to be powered? Yes. However, power is a tricky thing. Power is a test for a negative or a positive outcome.
Let's see, negative.
Negative. What's a test for a positive outcome? It's a hypothesis testing. It's the p-value when the test is not significant. Technically, a p-value is a test to make sure that how the risk of type 1 error, which is 5% if you're doing 95% confidence interval. A p-value tells you that this outcome I got, I'm more than 95% sure that the true mean of my finding is somewhere around that range, which is the confidence interval range. This is what a p-value tells you. It's a hypothesis testing to make sure how much, and we use the 5%, and if we want to put it in legal law language, we'll say lisinopril has decreased blood pressure by this much, and I am less than 5% sure I did something wrong, or I am more than 95% sure that this finding, this mean that, because in stats, numbers are not real. When you find a study that decreased blood pressure by 20, it's not 20. It's 95% between a range where the mean is 20. So the true value could be 18, could be 19. This is what a stats is. In stats, numbers are nothing, are a hologram. The actual value is somewhere around this number, and we do stats to make sure how much 95% sure that the range is close, the true mean is within that range. So power is a test for a negative outcome. Means that I came in, I did study, boom, insignificant. I did what? A negative results. Should I be sad? Should I cry? No. Negative results are still results. I need to publish. I need to say, this drug is not good. But just like this drug was working, I need to validate this. I need to validate it. Power is a test to make sure that your negative outcome is a true negative. So I could be for sure I say, because there is also a risk of error here, when I said, with every outcome, whenever I do a study, I get an outcome. Is it positive? Okay, now what? Is it true positive? Yes, that's p-value. I did a study, I got negative outcome. Is it negative? I don't know. Is it true negative? Do power and tell me. So power is the number you need to recruit to witness an event. Think of it as, when you had a negative outcome, means that you didn't have an event. When we do a cardiac study, we wait for patients to unfortunately die to validate this is what we event, because this is our null hypothesis. If the patient did not die compared to placebo, it means the drug worked. That's how we do stats. We're not waiting for them to be alive, we're actually waiting for them to be die. So when you do a study and you did not recruit enough patients, because you say, I want 20,000 patients so that in 5 years, this is the normal rate of dying. And if they pass that rate, that means the drug worked. If you did not recruit enough, you may not be able to witness an event within that period. You may need longer period. Power is the minimum number you need to recruit to witness an event within that period. So when you don't recruit enough, when you say the study was underpowered, means that you did not recruit it enough, you did not come with many events, and maybe the drug worked, but you did not recruit enough, and technically you didn't see an event, so you thought the drug is not working. Does that make sense? Mm-hmm. Okay, that's enough on power. More on that later. A level 2 is a level 1 without power. Level 3 is that's it. We're no longer interventional, we're doing observational. And when we do observational, is it prospective or retrospective? Which is better?
Prospective.
Spell prospective. Controlled?
Well, if it's observational, it can't be controlled.
That's what I'm gonna get to. Yes, there are some studies that are controlled, and I will talk about it.
You're right.
But it's controlled, but non-randomized. basically, because you're going back, you're not randomizing patients. But it is, you can have a control arm and look back. Power doesn't matter. A 4, it's the same thing, but it's a retrospective, but we are still controlled. A level 5 is, it doesn't matter if it's interventional. It doesn't matter if it's retrospective, prospective. It doesn't matter randomized. If a study that is not controlled, you're automatically a level 5. No, even if you are the biggest interventional, you have more than 50,000 patients, if you don't have a control arm, you are automatically the lowest level of evidence, because you're just like doing animal testing or human testing here. That's why our kinetic studies, our phase 1 studies, they are all level 5 because it's a single arm study. Single arm studies is automatic a level 5 patient, unless you could do the patient his own control, and that's like a different thing right now. Now let me talk about observational studies, because interventional will be discussing them. What are the observational studies? These are the fuel of medicine. These are, I know we all read of interventional studies, but there will be no interventional studies if there wasn't enough observational studies. Interventional studies requires a lot of time, lots of resources, and lots of money or personnel. In order for you to invest in such a big investment, you need to make sure that there is some kind of evidence there to support your investment. This is your observational studies. Observational studies are the main generator of practice. Any disease state, any side effect, anything you know about epidemiology was discovered through an observational studies. So what are the types of observational studies? We have 1, case report, case series. Every time I say case series, Siri will come.
Oh. Whoa.
Yeah. Third thing is case control. Fourth thing is cross-sectional. And 5th thing is the best of the observational studies, my personal favorite, cohort study. Okay, let's name, let's analyze. What's a case report?
Just one
patient. So case report, I can just do n equal 1. That's it. What's happening? I'm describing a case. Every disease state started off a case report. Every side effect started off a case report. I'm going to use AIDS here as AIDS was a case report, a single patient where patients got announced, we had a patient that has for some reason contracted this cryptococcus meningitis, CD4 was 0, something is going on right here. This is the main thing to start evidence, to that increase awareness. Does it change practice? No. Does it affect patients? Does it affect your pharmacotherapy? No. It's just going to be, the effect is, something is going on here. I better do more studies or look more. Anything starts off a case report. So after a case report comes in, what happened to the a case series started. Nice. Okay, case series is basically n more than 1. Sorry, not equal. So n more than 1. Technically, you're just reporting more than. You say 3 patients came in. Something is, when you have more number, you got more slide, And this is still, do we have a control group? No, we're still here in the 5. So this is, we have more. Say, 1 read the case report and say, hey, interesting. 3 patients on the floor have this type of cryptococcus meningitis, and they all have low CD count. Let's investigate, something is really going on. Now AIDS started to be, we don't call it AIDS, we don't know if it's HIV. Now, just like the first time I know. Now we do the best study to identify risk factors. All your risk factors, your smoking, your HIV and AIDS, smoking and cardiac, diethylstilbestrol and clear cell carcinoma of the vagina. All of these came in from case controls. Case control is controlled. Yeah. So you have 2 arms. Here we get up. So we're starting level 4. Look at case control here. Case control, we have 2 arms. Arm A, Arm B. Arm A have the outcome. Arm B doesn't have an outcome. What I'm gonna do is that I'm gonna take these patients who are dead, patients who are not dead, let's say for example, or patient with cardiac disease versus patient without cardiac disease. What I'm gonna do is I'm gonna go back, look up their file and lifestyle and try to identify what did group A got exposed to in order for them that happen. Now, is this causality?
No.
No, I cannot establish causality here, but I can establish what?
Risk factors.
Risk factors, which is a correlation. I can correlate the effect of being exposed to smoking to have a heart disease. That's why we use odds ratio here. Odds ratio is the testing tool for case control because it's an odds of having the outcome if you were exposed to this risk factor. So you start with an outcome and you go back in time to look for risk factors. What did this group A got exposed to? It most likely correlates with the exposure, and sometimes it doesn't. That's like correlation. Odds ratio is not etiology. That's why correlation is not causality. A nice review here. So what they had, they got patients with AIDS, patient without AIDS. They went back in time, did some testing, turned out the patients with AIDS are HIV positive. Here we go, it's HIV. They got patient with cardiac, patient without cardiac, got back in time, so that patients who got smoker have higher risk of contracting the disease. Here you go, smoking is associated. What's other than smoking? Let's check weight. Who's more? They are more obese. That's it, obesity and cardiac. Let's do sodium. They had more sodium intake. That's it, sodium. Let's do genetic, let's do age. All of these factors got identified by just doing case control. Actually, let me give you a nice example. In the 90s, a cholera outbreak broke in South America. South America, the continent. And I think, started off Ecuador and started to go up to the north and started to hit the shores of Florida. When the cholera finally hit the States, panic mode started and ways to identify, locate, and quarantine and control the outbreak. How do we know? Where's the source? It's probably something from water, right? That's how cholera gets started, but how do we know? So Stats-In came into the rescue. Statistics started to do, or epidemiologists I should say, started to do a case control. They got samples from different population, from the same, patients with cholera versus patients without cholera, and they got back in time and see what kind of they exposed to. And it turned out, after controlling, mango have the highest odds ratio, specifically a mango from a certain area in Ecuador. I think it was Ecuador or Peru. When they went and investigated the site, they found that the mango was being washed in a contaminated water with cholera, and that's how they located the source, and the outbreak was controlled, and the disease was controlled. That's what a case control. This is how beautiful case control is. Cross-sectional, I'll leave it. Let me talk about cohort. Cohort is the most beautiful, elegant observational studies. I love cohort. Cohort is basically what I call, it's like planting a seed and watching it grow. Because cohort, you don't start with outcome, you start with risk factors. In other words, you give a patient a cigarette and tell him, smoke, let's see what's happening. That's not how it is, but just for you to get an idea. So your starting point is a risk factor. You got patients with no risk factor. That's your control. And you're just gonna follow up, could be prospective, could be retrospective, because I can look up when did the patient start, I can pull off EPIC report and see patients who are smokers and look up from this point they started smoking, when did they develop a disease. Or I can just start today, give the patient a cigarette, never, and look them in the future and identify when they will develop an outcome, if they will develop an outcome. So this is risk factor, and you move in retrospect or prospective. It depends on when did you started the risk factors, and you look for outcome if it occurred. You are studying one risk factors or multiple. This is the best study to have what? Causality, yes, because you are literally focusing with the risk factors, looking for an outcome, instead of finding an outcome and try to correlate an exposure, a random exposure that could be or could not affect the outcome. Does that make sense? Mm-hmm. This is a cohort. Cohort, if it's prospective, it's level 3. If it's retrospective, it's level 4. And this is the only studies that can tell you incidence data, because incidence, not prevalence, incidence is defined as number of new diseases, divided by numbers patients who are with risk factors. And new diseases means something new, something prospective, means any new disease that happened. So that's why cohort study is the only study to check for incidence. Whenever you read incidence, you know there's a cohort study that gave you that number. And what kind of test do you use for cohort? We use odds ratio for case control. As for cohort, we use relative risk. The risk of being exposed, the risk of having the outcome from that risk factor. So that's why relative risk is the testing tool for cohort studies. Cross-sectional study is interesting. Cross-sectional study is a prevalence study where you do a head count. How much disease, to assess the disease burden. It's used by epidemiologists to know how much do I have patients, how much do I need to work, how many cancer patients do I have. So per a standard unit of time, I will just calculate the patients who have the disease versus the patient who don't have the disease. So that's a cross-sectional study. It's a prevalence study prevalence is how much you have, how many disease what is your disease patients, how many patients with the disease you have. Is that clear? I think I'll let you leave 5 minutes earlier. Actually, this is the first time I do well in time. I always abuse my time. This is actually I'm 5 minutes early, I should might say. And it's actually really good. Do you have any question? You know, DI pearls are not necessary to be in that depth. It's very short, but because the first pearl is not a pearl, it's part of orientation. That's why it is like this. But technically, DI pearl, you should not go on tomorrow like you're doing, and like on Wednesday when you're doing a pearl. It doesn't have to be that deep. Just make it anything. This is technically part of orientation. Interventional studies are for general clubs on Wednesday.
Where do the DI pearls using cardiac or like an oral?
No, it's in DI office, but I just did it here after clinical review because I will run up the hill right now. So no, not for me to go up and go down again. I just said I booked the class for an hour and a half, but technically DI pearl is in the office, in the DI office where it's just like very casual, non-formal. We just sit, you don't have to use a board, you can use a computer, doesn't matter, it has nothing to do with it. This is part of orientation. Okay. All right guys, you're off the hook. Thank you.
Wow. Are you gonna upload the video on YouTube?
No, on YouTube.
That's what I thought too when you.
I know, we should start like a Khan Academy.
Oh, like make a business out of my lectures.
We should. That's like a side job.
Oh no.